From the JAMA Network, this is JAMA's Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we will be discussing the article, Oncologic Risk of Missed Appendiceal Tumors and Acute Appendicitis. We are here with two of the authors, Dr. Maxine Germes and Dr. Maxime from the Department of Digestive Surgery, Sorbonne Université, Paris, France. Thank you both for joining us to discuss what is one of the most common general surgery diseases in the world, acute appendicitis, and really the potential impact of antibiotic-only management on missing appendiceal tumors, which I think is really the biggest concern for surgeons. So to start, can you tell us a bit about why you wanted to examine this and share with us how you did it?
Of course. Thank you for receiving us on your podcast. It's a great honor. So, the reason behind this study is that more and more over the world, doctors are starting to treat appendicitis with antibiotic only treatment. And a big concern for that, as you said, would be missed appendiceal tumors. And so we wanted to examine our own database that was constituted of over 3,000 appendicitis cases to see how many were in fact tumors after analysis in order to have a bigger picture of what we were dealing with concerning that risk.
I absolutely agree with that. And we know now of antibiotics treatment for uncomplicated appendicitis regarding the risk of surgical complication and recurrence. But data about tumor are leaking. And this is why we thought that this study was very important to be very safe when we propose this treatment for the patients. And I think an important point is that our data relies only on adult patients, and we have limited knowledge for children. Probably the risk of tumor is lower, but it must be specifically assessed.
All right, for our listeners who may not have had a chance yet to read the paper, can you recap your major findings of the 2,293 patients who underwent appendectomy, who had also a very good median follow-up of 34 months? And did any of these findings surprise you?
Yes, actually, they were a little surprising. We weren't expecting such good results. What we found were that incidental appendiceal tumors were mostly very small and low-grade NETs, and that aggressive malignancies were exceptional and occurred only, and this was very reassuring, in high-risk profile patients whom we detailed the criteria later on in the paper.
So overall, just to recap, NETs for our listeners, neuroendocrine tumors, which I think it was about 50% of the incidental tumors you found were neuroendocrine tumors. And overall, your prevalence of 1.6% of all incidental tumors really aligned well with reported rates of 1 to 2%.
That's right. We found approximately 1.6% of malignant tumors, and out of those, 22 were neuroendocrine tumors, and all were under 2 centimeters in size, and over 86% were inferior to 1 centimeter in size. And there were no recurrence of tumors after a mean follow-up of 34 months.
Such a great follow-up. And so I want to hone in a little bit, which you've alluded to already, in that specifically in comparing patients with malignant or pre-malignant lesions of the appendix and comparing those to the patients without, what differences did you find? What information did you gather, which then should help us decide as to who should undergo antibiotic-only management, who really would be at high risk?
What we found could have been not exactly predicted, but were sort of common sense, I think, which were age mostly. So we decided the cutoff would be 60 years old, according to literature and what our results were saying. And so we found that people who were older, people who had complicated appendicitis on the imaging, people who were in pain for a longer period of time, and we decided the cutoff would be 15 days, so a couple of weeks, which sounds obvious, but people who had metastatic lesions on the imaging that detected the appendicitis. So taking in all those criteria, we saw that they were significantly higher risk people who met all these criteria were significantly more likely to have a malignant lesion. And what we realized was that when we put all those criteria together and applied them together, that's when we could exclude with 100% certainty all malignant lesions except for NETs, the small NETs. Out of them, 17 out of 22 NETs would go under the radar with our criteria.
Just would like to add an interesting finding is that the CT scan is not good to find lesions in the appendix, as none of the patient with the tumor had a suspicion of lesion found on the CT scan. So it's important to know that the CT scan is helpful to select the patient regarding the diameter of the appendix, the complicated form of appendicitis, but the CT scan is not good to find tumors into the appendix.
And in reviewing your findings as well, I thought it was interesting, along with the longer median duration of abdominal pain and a more frequent radiologic suspicion of complicated appendicitis, was actually appendiceal diameter as well. And if I remember correctly, what you guys found was actually 15 millimeters was the cutoff. Is that correct?
Yes, that's correct.
And so I think, this really is the elephant in the room, so to speak, in the sense of, as of right now, the current standards for all incidental appendiceal tumors, I think it's really important that we note this, that the current standards for all incidental appendiceal tumors call for resection. And you highlight that with your selection criteria, which you beautifully went through, thank you, actually 77% of the neuroendocrine tumors and one low-grade dysplastic polyp would have met selection criteria for non-operative or antibiotic-only treatment. What are your thoughts on this?
Our thoughts are that for now, we don't actually know or have a lot of data on the malignant potential of these NETs. I think the most important thing in a practical scenario would be to explain this to the patient. So I think it would be more a patient collaborative decision. In the sense that we would tell the patients, well, you could have two possible treatments. You're young, the imaging is not concerning, etc., meeting all the 5 criteria we said before. And we would say, well, if we treat you with antibiotics, you have a 30 to 40% chance of having another appendicitis in the next few months or years. And therefore, we would have to operate if it's the second one. And on the other hand, if we don't operate, there's a very low risk of missing something malignant that might be a possible NET. And so we would have to explain to the patient what exactly we know as of today, what an NET is, and then let the patient decide or help the patient decide along those lines.
Yes, and this finding is in line with the new guidelines regarding the treatment of acute appendicitis published recently in JAMA Surgery, which recommend a decision shared for acute uncomplicated acute appendicitis. And we believe that this article encouraged the surgeon to discuss the risk of malignancy with the patient.
I love this, and I want to take this opportunity to discuss different management guidelines. And thank you for referring to the World Society of Emergency Surgery guidelines that, yes, the 2025 guidelines were published. And I think it's a really important thing to highlight on that algorithm is this shared decision making. And so could you share with us a little bit about how you're employing antibiotic-only management of acute appendicitis at your hospital? And what are you finding? Do you see any sort of trends in terms of what patients are choosing? If we're getting down that pathway, you're going to have a 25-year-old healthy individual tonight who comes in and you happen to be on call. Are you offering antibiotic only to every patient? that meets criteria? That's, I guess, the first question. And the second question is, what kind of feedback are you getting any sense from patients about this shared decision making?
For the moment, we are trying to modify our practices because we were proposing appendectomy to almost all of the patients. This is why we were able to do this article. But we know that we have to change that, and we try to modify our way to present the disease to the patient to help him to decide. But for the moment, the number of patients treated with antibiotics only is limited in our unit.
And I'm actually working in a different unit at the moment. I'm working in Guadeloupe, which is a very specific place to work in the sense that we very rarely get simple appendicitis. People seem to have a higher tolerance for pain. So when they do come in, it's more complicated appendicitis. But we did have some patients who were very young and met all the criteria. And we do here in our center propose antibiotic only treatment. And when we discuss this with the patient and let them choose, in almost all cases, they choose antibiotic only treatment and prefer to come back in later if the pain recurs and then have the procedure if it does, which for now, in my very small experience, it never has.
I love this. Well, thank you for adding that perspective. I think it's incredibly important. Well, Dr. Germes and Dr. Coleman, thank you both for joining me today to discuss your article, Oncologic Risk of Missed Appendiceal Tumors and Acute Appendicitis. Our listeners can find a link to this article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Have a great day, everybody.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.